Welcome everyone to this explainer. Today we are unpacking a really powerful framework designed by orthopedic surgeon Dr. Ramin Maharjan. If you've ever felt, totally overwhelmed by the sheer complexity of diagnosing bone, joint, and muscle issues, well, you are in exactly the right place. We're going to look at the clinician not just as a doctor, but as a clinical detective. Our goal? Gather the clues, map out the evidence, and safely guide the patient to the right outcome. Okay, let's dive into this.
So here is our roadmap. We'll hit the structured approach, taking an orthopedic history, the physical exam, neurovascular checks, spotting red flags, and wrap up with assessment and plan. Honestly, following this logical, repeatable sequence just completely takes the guesswork out of the equation. It ensures safe decision-making every single time.
Section 1. The structured approach. Let's organize the chaos.
When a patient walks into your clinic in pain, it can honestly feel like a giant puzzle with 1,000 scattered pieces. But here's the thing. As an investigator, your immediate job isn't to magically know every rare one-in-a-million disease right off the bat. Actually, scratch that. Your real job is just to accurately classify the problem. That is the ultimate goal here. We want to take all those chaotic symptoms and sort them into just one of these 7 buckets. Is it trauma, like a broken bone from a bad fall? Degenerative, like everyday wear and tear osteoarthritis? Or is it something a bit more insidious, like an infection or a tumor? Categorizing the issue right away paves the way for way safer, faster, and much more accurate referrals.
Moving on to Section 2, taking an orthopedic history. Time to gather the clues.
This right here is the first active phase of our investigation, the conversation. You aren't just making small talk with the patient, you are hunting for highly specific clues. Take the drug history, for example. Are they on steroids? Because that could severely impact their bone density and healing. Anticoagulants? Well, that completely changes the game for bleeding risk if they need surgery. And please never skip the social and occupational history. Knowing if your patient sits at a desk all day versus, say, working high-rise construction, that drastically changes how you view their activity level and what their recovery needs to look like.
To make sure you don't miss a single detail during that chat, we use a brilliant little mnemonic, OPQRST. That's onset, prior episodes, progression, quality, radiation, severity, timing, and associated symptoms. Now, I want you to really lean into sensory language, especially when asking about the quality of the pain. Don't just ask, hey, does it hurt? Ask them to bring the symptom to life for you. Is it a dull ache? A sharp, stabbing pain? Is it throbbing or burning? A burning pain might point you straight to a nerve issue, while a deep, throbbing pain, that could easily suggest inflammation or an infection.
All right, Section 3, the physical examination. Translating words into physical clues.
This is where we shift from just listening to physically investigating. But before you even lay a hand on the patient, you've got to remember the golden rules. Always explain the procedure, get their consent, expose the area respectfully, and, absolutely crucial, compare the injured side to the healthy side to establish your baseline. From there, your physical investigation is anchored by a classic, simple 3-step sequence: look, feel, and move.
Step 1 is simply to look. Just stand back and observe. We're scanning for swelling, bruising, obvious deformities, and scars from previous surgeries that might be hiding a story. We're looking for muscle wasting, which usually implies a chronic issue where they've just stopped using the limb. And definitely observe their gait. If they can walk, watch them do it. Seriously, simply watching a patient's gait as they cross the room can sometimes give you more clues than any single physical test on the exam table.
Step 2 is feel. This is gentle palpation, and it brilliantly highlights the sensory nature of ortho. You are literally feeling for the diagnosis. Check the temperature. Is the joint radiating heat? Because a hot joint is a massive clue for infection or active inflammation. You're feeling for effusion, which is excess joint fluid, and of course you're feeling for crepitus. If you felt it, you know it. It's that unmistakable, gritty, grinding sensation right under your hands when the joint moves. It tells you exactly what's happening right at the surface of those bones.
Step 3 is move. Here we really have to contrast active range of motion against passive range of motion. Active means the patient moves the joint themselves, using their own muscles. Passive means they totally relax, and you, the clinician, do the moving for them. By comparing the two, you uncover exactly what's restricting them. Is it just a gradual end-range stiffness from arthritis, or is it a sudden, hard locking block? Because that might mean a piece of torn cartilage is physically wedged inside the joint space.
Section 4. Neurovascular checks.
testing the wiring and the plumbing.
Listen, an orthopedic exam is absolutely never complete without this step. You might have diagnosed the broken bone perfectly, but you still have to check the limb's critical life support systems. For the wiring, you check motor function by testing muscle groups and sensory function using light touch or a pinprick across specific nerve pathways, the dermatomes. Then, for the plumbing, the vascular side, you've got to palpate those pulses, check the capillary refill in the toes or fingers, and note the skin color. And remember, as a good detective, you don't just check right where it hurts. You must check the neurovascular status, both proximal and distal, above and below the injury, to ensure the signals and the blood flow are making it all the way through.
Section 5. Spotting red flags. Navigating the danger zones. And this is where things get urgent.
Up until now, we've been gathering our clues pretty methodically, but now we have to shift our mindset. Spotting a red flag completely changes the urgency of your management. We need to sharply contrast routine mechanical symptoms against systemic red flags. Routine mechanical pain, like, say, a knee that aches after a long run or feeling stiff in the morning, that's standard stuff. But what if the patient reports a sudden fever or unexplained weight loss? What about night pain that wakes them from a dead sleep or a total inability to bear any weight at all? Those historical clues are glaring alarm bells for things like infections, tumors, or severe spinal emergencies.
Treat these specific clinical findings as a massive medical speed bump. If you encounter any of these during your exam, you are likely dealing with a true emergency. Extreme pain when you passively stretch a muscle, especially combined with tight, swollen compartments, that screams compartment syndrome, which can literally cost a patient a limb if you don't act fast. An absent pulse, that means no blood flow. And a hot, red, highly painful joint with a systemic fever points straight to septic arthritis, an infection that destroys cartilage incredibly fast. If you see these, your investigation escalates instantly.
Section 6. Assessment and Plan. Time to solve the case.
You've interviewed the witness, investigated the physical scene, checked the wiring, and swept for danger. Now it is time to synthesize those clues. Notice how perfectly the framework snaps into focus when we apply it to a real-world scenario. Let's walk through this case study row by row. We have a 45-year-old patient with a twisting knee injury. Under history, our OPQRST analysis revealed mechanical pain, swelling, and a sensation of giving way or instability. Moving to the exam row, we looked, felt, and moved. We found swelling, joint line tenderness, and a reduced range of motion. Because we followed the structure, the assessment basically writes itself. This is a suspected ligament or meniscal injury. And finally, the plan. We order imaging, advise rest, and initiate an ortho referral. It's just seamless, logical clinical deduction.
Your final action steps are always going to fall down one of two paths. Based on your investigation, did you uncover routine damage? If so, you'll proceed with routine management, schedule some follow-ups, maybe order an X-ray or an MRI, and provide immobilization like a brace or a cast. But if your detective work uncovered any of those high-stakes red flags we just talked about, you immediately bypass the routine stuff and trigger an urgent or even emergency referral to orthopedic services.
By mastering this structured approach, you've built a rock-solid foundation for diagnosing orthopedic patients safely and accurately. But what happens when the stakes get even higher? How does this exact same clinical detective toolkit apply to high-energy trauma and complex bone fractures? Well, that is a fantastic question, and it's exactly what we'll be diving into from Module 3. I really hope this explainer has left you energized and eager to tackle your next clinical case with confidence. Thanks so much for joining me on this deep dive, and keep learning.